Good afternoon and welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out the program evaluations and turn those back in at the back of the auditorium. Today I have the pleasure of introducing Dr. Robert Shapiro. Dr. Shapiro attended medical school at the University of South Carolina before doing his residency in internal medicine at the University of Virginia, and from there he moved to St. Louis, where he did his interventional and cardiology fellowships at WashU, and he's here today to update us on current topics in interventional cardiology emergencies. And please join me in welcoming Dr. Shapiro.
Thank you. Well, I want to thank everyone, first off, for inviting me to talk today and for coming. I'm going to talk about the current topics in interventional cardiology emergencies. And, it's a kind of a diverse group, and it's a fairly subspecialized topic. So if there's anything along the way that is not making sense to you, please stop me and ask any questions. I didn't make a disclosure slide, but I don't have any disclosures relevant to this talk. So just to start off with, the vast majority of interventional cardiology emergencies revolve around ST elevation MI. So as an outline, I wanted to kind of go over the guidelines just briefly, just to focus on some things that, have changed in the last few years, just to refresh everyone's memory. I'd like to review a few of the key concepts that are pertinent specifically to Mary Greeley, being a hospital where we have interventional coverage some of the time, but not all the time. So there's some kind of nuanced recommendations within the guidelines with regards to that. And I also wanted to talk about some new technologies to kind of show you some of the interesting things that we're doing in interventional cardiology. So this is the algorithm from the most recent guidelines in 2013. These are the AHA and the ACC guidelines. And so I think it projects reasonably well. So when a patient presents who is a candidate for reperfusion, really the left side of this flow sheet is the preferred method. So ideally, they're initially seen at a PCI-capable hospital, which we are a lot of the time. And then we take them emergently to the cath lab for primary PCI with a goal of first medical contact, meaning when they are first seen by either EMS or first seen in our ER, to device time of less than 90 minutes. And so, the goal there is usually primary PCI as opposed to emergent CABG or medical therapy. I'll talk briefly about the other side of the algorithm a little bit later. So really the mainstay of therapy is primary PCI. So the time is muscle algorithm is really still the mainstay of treatment for acute myocardial infarctions. And like I said, the goal time is less than 90 minutes, although we're trying to push that to probably less than 60 minutes as we can on a case-by-case basis. And then, it's time based on a first device. And so we'll talk briefly about the devices because I'm certain that you may be aware of some, you may be aware of not aware of others. And so I think this will be an interesting topic. So again, the mainstay of therapy continues to be balloons and stents. These are devices that have been tried and true and have been used from the outset of percutaneous coronary intervention. It's been using balloons, which are passed over small wires using a modified Seldinger technique to dilate lesions within the coronary arteries and then deploy stents. So on the here you see kind of a representation of a balloon. There's radiopaque markers, which allow us to know exactly where in the vessel the balloon itself is, so that when we inflate it, we're only inflating at the portion where we want to dilate. And here are two pictures of different types of stents. So these are kind of wire mesh devices, which are loaded on a balloon. So these are in the inflated form. And then positioned between, again, radiopaque markers here, and then positioned over areas of stenosis to hold that area open after deployment of the stent. The goal really is to prevent restenosis, which was a major problem with doing just balloon angioplasty, as well as abrupt vessel closure, which was a huge problem in the early days of percutaneous coronary intervention. So one of the devices that you may be less familiar with is actually aspiration thrombectomy. So here are two different kinds of devices. And what these are these are catheters, which are hollow plastic tubes, which have two lumens. The first of which you see right here is where we're passing this over the wire that's inserted into the coronary artery. And the second lumen here, or here, is actually hooked up to a vacuum suction. It's a syringe that is a vac lock syringe that can be locked in a suction. And then we're trying to aspirate thrombus and also maybe some plaque debris into the lumen of this catheter. So down here you see a graphic representation of a stenosis within a coronary artery with red clot adherent to the ruptured plaque, which would be the pathophysiology of an acute MI. And so the goal here is to remove the clot so that we reestablish flow and we prevent the clot from going downstream in the vessel and then causing decreased blood flow downstream. And so really the goal of this is to remove as much clot as possible. So here is a representative example of a large amount of thrombus that was removed from a coronary artery, but it can vary in size, and some of it is red clot, some of it is white clot, which is platelet rich. We also sometimes get fatty material, which suggests that we can also aspirate some of the plaque as well. And so the reason we do this is a meta-analysis that was recently published, showing that really there's a mortality benefit. It doesn't project that well, but I think the mortality when you do aspiration thrombectomy is about 2.7 and 4.4 if you just do balloon and stenting. So there is a statistically significant mortality benefit to doing aspiration thrombectomy. Compared to, there are mechanical devices that try to break up clot, and those actually had a higher mortality in acute MIs. And then embolic protection devices are basically filters which try to catch clot to prevent it from going distally, and those showed no benefit in acute myocardial infarction. So this is a case from actually Monday. So Monday morning, this is actually my patient. He presented to the ER with acute onset of chest pain. He's a 68-year-old gentleman who actually has a history of coronary disease, has been stented in his left side. And so here's an angiogram of his right coronary artery, which is totally occluded in the mid portion here. You see that the contrast should be flowing down kind of like a C, and it's pooling there. So this is actually the aspiration thrombectomy device. So all you see of it is the radiopaque marker at the tip. So what we're doing is we're aspirating thrombus from this artery. And so this is after one aspiration. So now we've established flow distally. So it's sluggish. It's kind of what we call TEMI 2 flow because it doesn't go down briskly. And there's still a filling defect here, but it's not staining. So this suggests that this is probably a very bulky plaque within the artery, meaning that there's not a hangup of dye, which suggests a lot of fresh thrombus. So we balloon that. That's a balloon being inflated. And then here, this is actually a specialized intravascular ultrasound catheter. So what this allows us to do is visualize the inside of the artery. We can look at where plaque is, and then we can use that to help us size our stents, both the diameter of the stent and also the length of the stent using these radiopaque markers on it. And so that's what we're doing here. We're trying to go from normal vessel here to normal vessel here and cover this area of plaque. And the thing about the IVUS really is that we see that the vessels are more diseased when we look at them under ultrasound than we appreciate angiographically. And so we usually use slightly larger stents. So this is a stent. It's loaded on a balloon and is placed over the wire that's distal in the RCA. And we'll position that with an injection. And then once we're satisfied, we'll deploy it. So we blow up the balloon, and that will press the stent actually up against the wall of the artery. And then once we let that down, then we take a picture. We see that the vessel is open. We really have no residual stenosis here. So it actually is a great result just with primary stenting. And here's our final shots. See the stent is between here and here. It's a little bit of a step down here, which is okay. We look at it with IVUS again, since we already have it. So that's the intravascular ultrasound. We can see that there's no plaque or thrombus protruding through the stent, and there's no tears in the vessel. We look at it in multiple views so that we make sure that we're not missing anything that may be eccentric, meaning that we wouldn't see it in one view but might in the other. So that's that's kind of our ideal result. We get it open very quickly. We don't have any distal embolization of thrombus, and he's this was Monday. He's been discharged today, so he did very well. That there is a clot there. So he presented with inferior posterior ST elevation. So clinically, the pathophysiology of ST elevation MI usually is rupture of a lipid-rich plaque, and then you form thrombus on it. Sometimes it's more convincing that there's a lot of clot there, and I'll show you a case in a few minutes where you'll see that the fresh thrombus actually stains with dye, so there's dye hang up there. That's very suggestive of at least a large amount of clot. In this case, clinically, the suggestion is that because he presented so abruptly, that there is at least some amount of clot there. And, the aspiration, in this case, we got just a teeny bit of clot. So I think that the major problem for him was actually the bulky plaque. And that's actually not in this case. So I think that it's kind of tough to know. It's kind of a clinical decision when you're working very quickly to try to get it open. Yes? Yeah, so that's a great question, and it kind of varies on a case-by-case basis. In general, so we have two of these VacLock syringes. They're about 25 cc syringes that are vacuumed and locked open. And I put both of them on, and then so I kind of place it right proximal to where the abrupt closure of the vessel is, and then slowly advance it. And as I'm doing that, I'm watching that there's blood flowing into the syringe. As it stops, that suggests that either we're occluded distally, and maybe we're having a problem because we're in a stenosis, or secondly, sometimes if you suck a very large clot, that'll actually stop the flow of blood. And generally, that's kind of a clue that we need to go ahead and pull the aspiration catheter out. The risk of doing this actually is that the goal is to pull the clot out in the catheter. If you have a very large clot, there's a risk that you could pull it out and then dislodge it in the aorta or within the coronary and embolize it either up to the cerebral system or somewhere else, or distally into another vessel. So the key thing is watching that we continue to have some suction and then getting it out pretty quickly thereafter. Any other questions? So just to talk briefly about intravascular ultrasound, this is it's becoming one of the mainstays of interventional cardiology, in that it really is a key technology with helping with stent length, diameter sizing, visualization of the stent complications, making sure that stents are well expanded and well opposed, and then also for doing more complicated procedures for defining, for instance, where bifurcation lesions start and end, and also for better defining where the ostium of the vessel is located, because especially in stenoses that involve the ostium, if you don't fully cover that with a stent, you're high risk for restenosis. So here we see an IVUS catheter. There's an ultrasound array that gives you a 360 degree picture in this metal portion here, and then this is passed over the wire that's inserted in the coronary, and like I said, we have these radio-opaque markers which help with the length sizing. So, and here is just a still frame showing there's a stent, these kind of white areas here are stent within a coronary artery. Here, this whitish area, this is a plaque that's being pushed up against the wall. this is kind of normal vessel wall over here. So we get a lot of detail from this, and this allows us to see a lot more than just angiography alone, and it improves both coverage of plaques using longer stents and making certain that we don't have complications that may predispose patients to either abrupt vessel closure or restenosis over time. So just to recap briefly about ST elevation MIs, again, the mainstay is balloon angioplasty and stent implantation, which we showed you. Aspiration thrombectomy is given a class 2A indication because it has data for lower mortality and a reduction in cardiac events. And then I'll talk briefly about one of the kind of novel techniques, which is laser thrombectomy, which can be used as an adjuvant therapy, especially if you have a very high thrombus burden. So laser is a technology that's been around for several years, and for a while there was some concern about injuring the vessels, and so it kind of fell out of favor, and then is now coming back into favor with a better understanding of how to perform it. And so it works by multiple mechanisms, which I'll explain in just a few slides. And like I said, it's especially useful if you have a lot of thrombus. So, the first mechanism by which a laser works is a photochemical breaking of molecular bonds. So it's a UV light pulse. It's actually a cold laser that hits tissue for about 135 nanoseconds, which is just the duration of the laser pulse. And it has a very small penetration, so it's only 50 microns, which makes that relatively safe within the coronary vessels. And so as we do this, it actually breaks the molecular bonds. But after the energy is emitted and the laser is turned off because it's pulsing, there's really no more of this photochemical mechanism. The second mechanism is actually a photothermal, in which the absorption vibrates the molecular bonds of plaque, and that heats the intracellular water. And as the water vaporizes, molecules break apart and the cells rupture. And so you get this formation of a vapor bubble, which forms over a much longer period of time than the actual duration of the laser pulse. And so that expands over 100 millionths of a second. And that's 1,000 times the duration of the actual laser energy emission. So, much longer effect. And then we have a third effect, which is actually a photomechanical effect, whereby there's expansion and collapse of a vapor bubble. And that actually breaks down tissue and clears byproducts from the tip of the laser. These byproducts are water, gas, and very small particles. And the importance here is that we want very small particles because as you go down the coronary tree, you get to microvasculature. And the larger the particles that are embolized distally, the more likely you are to occlude the microvasculature and then have poor coronary flow thereafter. So this is a process that happens over an even longer period of time and breaks these particles into very small particles. And so what you'll see is very good microvascular flow, even with large bulky plaques or large thrombus that's been broken down by the laser. Specifically for thrombectomy, because it can be used also for bulky atherosclerotic plaque, the high water content of thrombus helps with the absorption of the laser, and you have acoustic shock waves that actually break up fibrin and disrupt clot in that way. And then the laser also alters platelet aggregation by causing platelet stunning, which is important because in acute MIs, the milieu of thrombus forming particles and is such that you're more likely to form new clot in an area where you've had old clot, and so actually having stunning of the platelets helps decrease reformation of platelets over the area where you have an acute thrombus. And like I talked about briefly, the main goal is that we don't want a lot of distal embolization, because if we just embolize large parts of thrombus, distally, then we end up having very poor flow, and then we have a poor result because of that. So I'll show you a case. This is a lady. She was an 87-year-old. She had a history of heart failure, diabetes, atrial fibrillation, and Guillain-Barré syndrome. She had had breast cancer and was status post mastectomy, hyperlipidemia, and hypertension. She presented with acute onset of dyspnea and chest pain. Her initial troponin was mildly positive at 0.6. Her ECG is as such. Obviously, someone circled V4 and V5. You could argue whether you think that this is an ST elevation MI or not. You do have some kind of subtle ST elevation in lead 3, which wouldn't meet clinical criteria for an ST elevation MI, but clearly it's a very ischemic looking ST depressions, suggesting that there's maybe a posterior component depending on where the leads were placed here. You also have some ST depression in the high lateral leads, and maybe a little bit of ST elevation in AVR. So she was brought emergently to the cardiac catheterization lab. And these are the views of the left system. So I know you're not used to looking at coronary angiography, but we basically take angiograms and multiple projections to look for stenoses, especially eccentric ones that may be more visible in certain projections and less visible in others, or maybe the vessels are overlapped and maybe hiding things. So this is kind of the mainstay of how we diagnose coronary artery disease invasively. So really, there's nothing too exciting on these images. I will point out, you see here, there's a vessel right there. So what this actually is that, so this is the left anterior descending coming down here, and these are collateral vessels. So these are kind of bypass channels that the heart itself has made to a vessel that has a severe occlusion. So this is actually the distal right coronary artery, which you're seeing filling backwards from kind of bypass channels that the heart has created from the left system. So there is some chronicity to her having a problem with her right coronary artery. And so here, let's see. So here is the right coronary artery. So this is what I was talking about earlier with staining of acute thrombus. So you notice that there's a hazy area that's already has contrast in it before the injection. So when there was a test injection, this area, which is a large amount of fresh thrombus, takes up some of that contrast and it doesn't clear it. So that is very suggestive of a large amount of thrombus right here. And so we see that there's an acute closure of the mid right coronary artery here. And we think that there's some chronicity to it because of the collateral flow and the distal vessels already being filled in a retrograde fashion from these bypass channels over on the other side. So given the fact that we saw a large amount of clot already, the decision was made to primarily use laser, atherectomy, and thrombectomy as our primary mechanism of opening up the vessel. So without ballooning, without doing aspiration thrombectomy, we just pass the laser through here. And this is, with 2 passes. So with the first pass, you see that we've reestablished flow distally. There is there's still clot here, and there's still plaque. So areas where it's hazy and it's kind of less dark. So right here and here. And then even with the second one, there's still some of that, but it's much better. We see that we have good flow distally. We haven't embolized any of that large amount of thrombus distally. This is really the benefit of doing a primary laser atherectomy and thrombectomy. So next, we just deployed a bare metal stent. She had a history of a left temporal AVM with hemorrhage into her brain. So we wanted to use a bare metal stent so we could limit the duration of dual antiplatelet therapy. One of the most important things we decide before we do the case is whether they're going to have surgery or if they have bleeding problems, which may limit the duration of when they can be on aspirin and Plavix or Brilinta or those related medicines because there's a higher bleeding risk when you're on both of those. So this is our final result. So, very quick case, 2 passes of the laser, deploy the stent, IVUS it to make sure that it looks good, and then we're done very quickly. So excellent result, no distal embolization. This is one of the kind of novel uses of a laser within the coronary arteries. So I want to talk briefly about the right side of the STEMI algorithm because we do, unfortunately, not have 24/7 cath lab coverage here, so it is something that we occasionally have to think about at Mary Greeley. So on those unfortunate times when the cath lab is not available or one of our interventional cardiologists is not available, the goal is to have patients come in to our emergency room and out in less than 30 minutes. And in general, the goal is to try to get them to a primary PCI center such that they have a first medical contact to device time of less than 2 hours. And if it's going to be greater than 2 hours, if the weather is bad, we think that there's going to be some delay, then really those patients should get fibrinolytics. And that's really standard of care. And I know this is important because we're going to be starting to be involved in the ACTION registry and kind of looking at all, collecting this kind of data for our patients. In the state of Iowa, we're going to be a group of many of the STEMI capable hospitals to try to collect data on this. So we want to do a good job of this. And then after they get fibrinolytics, if they end up on that pathway, then generally those should be transferred as well because there's a fairly high rate of failed reperfusion or reocclusion. And so those patients should go for urgent PCI. And also, there's an invasive strategy taking patients within 3 hours to 24 hours for actual coronary angiography and PCI, even if they have successful reperfusion after fibrinolytics. And so that's just kind of recapping, so I'll skip that. So I wanted to switch gears briefly and give you another patient presentation. So this was an 87-year-old lady. She had hypertension and she had aortic stenosis. And this was when I was still in St. Louis. She presented to a referring hospital with chest pain and shortness of breath and ruled in for a very significant non-ST elevation MI. Her troponin peaked at about 150, which is pretty high. She was noted to have critical AS with a valve area of 0.4. And they did a diagnostic coronary angiogram, and that showed a culprit lesion in the proximal LAD and at the bifurcation with the first diagonal branch. So she was referred actually down to Washington University for transcatheter aortic valve replacement evaluation and for management of her acute coronary syndrome. With medical therapy alone, her troponin had trended down, and so she was evaluated by our valve team and deemed to be at very high risk for a surgical aortic valve replacement with an STS score of 8 for the surgical valve replacement and CABG, which she would require. And so we plan to do a complicated percutaneous coronary intervention of her bifurcation lesion in the proximal LAD and the first diagonal prior to her getting her valve worked on. So here are some initial views. So what you see, there's a severe stenosis, a little bit overlapped here, but it's right. This is the LAD coming down this way. This is the first diagonal, which is a large vessel coming out laterally, and a little bit different view. Severe stenosis right here, and LAD coming down here, first diagonal coming down there. So we started with just balloon angioplasty to open up that severe stenosis to start with. We had 2 wires down protecting the large side branch and also the LAD. And this is just a angioplasty result. I think this illustrates why angioplasty alone is probably a substandard method of dealing with coronary stenoses. We see that we really have, kind of poor flow, and we haven't really accomplished much by way of improving this area of stenosis with angioplasty alone. That's really why stents are the mainstay of therapy. So here we have a stent. It's in the LAD from the proximal to the mid portion. And then we have a balloon in the diagonal branch to try to protect the ostium of that large branch. The issue is that when you blow up a stent, you can actually push plaque into the side branch. You can push the carina of the bifurcation into the side branch and occlude that large side branch. And we thought that she'd get very sick if we did that. So here is deployment of the stent. And then we're going to inflate this, what's called a jailed balloon. So this balloon is behind the stent, between the stent and the vessel, and then it's kind of poking right into the ostium of the side branch. We inflate that to preserve the carina, open up the ostium, and then we reinflate the stent balloon to reoppose the stent to the vessel wall. So then, unfortunately, she became hypotensive and bradycardic. She was given atropine and phenylephrine IV. And this is the next shot. So she really has no flow down the coronary. So you see that the flow ends right here. It ends right here. No reflow is a phenomenon that can occur with stenting or ballooning of large, bulky plaques. In this case, probably more a function of the fact that she's now in cardiac arrest. And really, there's very little cardiac output. So we initiated CPR. We gave her epinephrine ×3. We started a norepinephrine drip. She went into an unstable SVT at 200 beats a minute. We cardioverted her, emergently intubated her. And then we did get improvement in the flow. So, with all these medications, with CPR, we have return of spontaneous circulation. We do have improved flow. It's not ideal, but it's much better now. So unfortunately, she arrested again. And so the decision was made to deal with the valve because patients with critical AS do not do well with cardiac arrest. And in general, they fall off the Starling curve very quickly. And oftentimes the ventricle just dies, and then you really can't recover them without excessive measures. So here, what I'm going to show you, you've probably never seen, is a balloon valvuloplasty. So this is a large balloon which is placed across the aortic valve. You see this hazy area, that's calcium in the leaflets of the aortic valve. So this has been placed across the valve and then inflated to crack that valve open and to increase the aortic valve area. You will probably never see a picture like this again. And the reason I say that is that in general, what we do when we want to do a valvuloplasty is that we pace patients at a high rate at about 180 beats per minute to simulate ventricular tachycardia so that their cardiac output falls off and so that this balloon is not ejected out of the ventricle. In this case, there's no pacer. And so effectively, she has cardiac standstill. Her heart is completely dead, and we just blew the balloon up quickly and then gave her more medications and then decided that she needed more emergent support. So I want to talk briefly about hemodynamic support because I think this is one of the topics that you probably are not familiar with in interventional cardiology, and there's been some big improvements in this over the last couple of years. So in this case, what we decided to do was place a percutaneous catheter-based pump which can support the ventricle. And so depending on which one you choose, they can provide about 2.5 to 5 liters of support. So 5 liters per minute would be full hemodynamic support. So basically it's just getting a wire across into the ventricle, placing this catheter in there, and then there's an inlet port and an impeller within this area, and then it sucks blood from the ventricle and ejects it out here in the aorta, and then improves the hemodynamics of the patient. It unloads the ventricle and improves blood flow as well as blood pressure. So this is specifically hers. So this has been placed. The aortic valve is right here. So there's the inlet port sucking blood and ejecting it here. And one of the issues that, she got a lot of medications. Unfortunately, when you're not circulating medications, they don't really help you very much. So as soon as this was placed, then the medications like epinephrine, norepinephrine that have been given were now circulated. So she had actually very brisk recovery of actually a hypertensive blood pressure with hemodynamic support. And we left this in and ended the case. And so she was transferred to our cardiac care unit. Unfortunately, one of the issues with hemodynamic support is vascular complications. So the device, which is called an Impeller device, was removed on the next day, but she was able to have her pressors weaned. Unfortunately, her course was complicated by an acute gastrointestinal bleed with a mucosal tear at the GE junction and a bleeding gastric ulcer, which was treated with injection and thermal therapy by our gastroenterologist. And she did require 7 units of packed cells, but was eventually transferred to the floor. She recovered to discharge, and actually a few months later, she was able to come back. She did receive a transcatheter aortic valve replacement and did very well with that and went home after that, doing very well. So it's actually kind of a terrible complication, an emergent case, which ended up with the patient doing exceedingly well and actually getting everything that she needed done. So just to talk briefly in the last couple of minutes, I wanted to go over a few of the hemodynamic support mechanisms that we have in interventional cardiology. So the intra-aortic balloon pump is kind of the tried and true old method of hemodynamic support. And then the Impeller, the Tandem Heart, and ECMO are some of the things that we've been using in the last few years to support our patients in interventional cardiology. And then each has kind of benefits and detriments based on the specifics of how it works, and the level of cardiac support is very different depending on the device. Some of them increase the cardiac workload, which means that the heart is actually working harder and it's not recovering, whereas some of them decrease the cardiac workload and allow the left ventricle to recover over time. And mostly that's based on either effects on afterload, either increasing that, meaning increasing the blood pressure that the heart is pumping against, or decreasing it, and then unloading of the left ventricle, meaning kind of decreasing the preload of the heart and putting them back on the Starling curve. So the intra-aortic balloon pump, what you see is it's a large balloon. These are some pictures, deflated and inflated. It's placed in the descending aorta. And then it's timed to inflate in diastole so that you get a pressure wave of increased diastolic pressure, which helps with coronary perfusion. And then it deflates during systole so that when the heart pumps, there's actually a negative pressure and it slightly increases the cardiac output by decreasing the afterload at about 0.5 liter per minute. So it's very minimal hemodynamic support. And the latest randomized studies have really shown that there's no mortality benefit to using an intra-aortic balloon pump in shock or in, especially in cardiogenic shock and acute MI. But it is one of those things that's been deemed as reasonable if someone doesn't quickly stabilize, because it can offer some some mild amount of support, and it can be placed relatively quickly. The guidelines also recommend these alternative left ventricular assist devices for circulatory support in patients with refractory cardiogenic shock, especially in the setting of acute MI. And so just to talk briefly, extracorporeal membrane oxygenation, you may think of with babies or in patients whose lungs are not working, because what it allows us to do is to pass blood through a membrane oxygenator such that we can take deoxygenated blood and then return oxygenated blood. In general, VV ECMO is used for patients whose lungs are not working to just generally oxygenate the blood. VA ECMO is more commonly used in interventional cardiology, and really what we're placing a large cannula in the venous system, taking blood out, oxygenating it, and then and then pumping it into a large cannula in the arterial system. And this can actually fully support patients, around 4.5 to 5 liters per minute. But the cost is that the heart is pumping against a large amount of blood flow, which is retrograde in the aorta here. And that increases the afterload, that increases cardiac work. And so the heart is not necessarily recovering during this, although the patient is fully supported and their perfusion of the rest of their body is maintained. The Tandem Heart device is similar to ECMO. It uses large cannulas. The venous one is placed all the way up and across the interatrial septum into the left atrium. So that requires a transeptal puncture with a needle. So that is a complicating issue. The benefit of this is that it's taking oxygenated blood from the left atrium and it's unloading the left side of the heart and then pumping it into the arterial system through a large cannula in the arterial system here. And then finally, the Impeller device that I spoke of briefly is a percutaneous ventricular assist device, which uses an axial impeller or propeller, which is inside of this device. And the pigtail end is placed within the left ventricle. There's an inlet area where blood is sucked by the impeller up, and then an outlet area where it's ejected into the aortic root. And then that offers support, both unloading the ventricle and improving blood pressure and peripheral perfusion. And depending on which device you use, it can offer between 2.5 and 5 liters of support. So I just want to kind of go over, some of those options for hemodynamic support, because I think those are some of the things where in interventional cardiology, especially for acute MI patients who are decompensating, who are in cardiogenic shock, these are some of the tools that we use to try to maintain them, to try to allow us to complete a full revascularization. And there is data that use of these devices does improve the amount of complete revascularization that can be accomplished safely. And those patients actually do better than just using medications or minimal support with things such as the balloon pump. So with that, I think my time is about up, so I'm happy to answer any questions. Jen? We don't have the Impeller right now. So I think that, it's one of those things that I think we need to kind of look into and see. I think that it would be a good device, especially for our patients if they decompensate and need to be transferred elsewhere. And there's probably a role for it also in heart failure. So not even in coronary artery disease, but in acute decompensated heart failure. I think that it would be a reasonable thing to consider for our patients. So, just being new here, it's one of those things that I would like to look into and decide how. No, it's very different. So basically it has a console which allows you to dial in how fast you want the impeller to go. And so effectively you can dial it up or down as whichever amount of support you want to give. And then there's a 2.5 device and there's a CP device, both of which are inserted percutaneously through the femoral artery. The 5.0 device is surgically implanted, so we would never have that. But the CP device can offer about 4 liters of support, and the 2.5 is about 2.5 liters. And then effectively they can be turned up or down as you need. That's a very good question. At Barnes, for a while, we had the record, which I think was about 45 days. And that was actually an axial one. But they can be left in it depends on the patient's anatomy. The issue is that you're using a 14 French sheath. So each French is a third of a millimeter. So it's a relatively large sheath. And so depending on how their peripheral vasculature is, the perfusion to the distal limb is a big complicating issue. So generally we try to get them out within a few days, but they can be left in for longer if they're perfusing the limb well.
A couple of questions regarding the Impeller. I assume that there is a rather high RPM of this instrument in a small space. Is there any problem with hemolysis, red blood cell destruction?
Yeah, that's a great question, and they have had some problems with that. They've actually redesigned the device to some extent to limit that. Especially the CP device, when it first came out, had some problems with hemolysis, and so in general, the patients are, they're kept on full anticoagulation while this is in, and then we generally monitor hemolysis labs to make certain that they're not having hemolysis. One of the things that can be done is that, by turning down the support level, that will actually reduce it. Obviously, at the highest level, the hemolysis incidence is higher.
Well, better to have flow than no flow at all. So.
Absolutely.
The second question about the laser. I assume that the laser beam is directed down through multiple fiber optic fibers.
Correct.
Therefore, is the beam directed in a straight line, or is it in a spread configuration at the tip?
It's in a straight line, and usually what we use...
Straight line down through the, straight ahead from the tip of the catheter.
Correct. And then the main benefit is that you get the vapor bubbles, so that forms a lot larger area. So in general, it's a straight line, because the issue is that we don't want to cut the sidewall of the vessel. So one of the contraindications of the laser is if you have a severe tortuosity where you're going to be going, because if you think of it, if you're kind of coming directly at the wall right there, you can actually perforate the vessel. So in general, it's a straight line, and then the vapor bubble expands a lot larger. So the diameter that's treated is really based upon the vapor bubble. And then there are even more advanced techniques that are not generally used in native vessels, but within stents, we can use it injecting dye. Generally, we inject saline through it to clear the area. And then we can kind of create even larger microbubbles with injecting dye during the laser. We usually only do that within stents, but that'll actually form an even larger bubble.
I just have a comment, but first, the door-to-balloon time by chance on the Monday morning case that you showed us first?
Yes, I think it was 50 minutes, so that was
50
very
minutes. So I guess my comment is just to everyone, and kind of a thank you and a kudos too, just so what that means is from the time that patient entered the door to the ER until the time that his vessel was open, or the balloon was open, or the expiration catheter was used, was 50 minutes. So, I mean, we talk about that every day like it's not really a big deal, but, that's a lot to be done in 50 minutes. The ER has to first diagnose that, get an EKG, get them down there. Dr. Shapiro has to gain access, get all these small stents and balloons in there, and open the artery when you have a patient that's usually unstable and sick. So I just wanted to put out a thank you and let people know what that really means and what a good job the team did to get that done in 50 minutes on Monday morning before 8 o'clock. So.
Okay, well, thank you everyone for coming.